Ada. Okey.
Lepas tu yang diorang buat.
Ini dia memang dah on dah ni kan?
Hah?
Hello.
Cik nak tahu ada on ke tak?
Itulah. Kalau I start video.
Oh, ini video ini. So yang screen tu. Azri. Aku rasa kau lagi tahu kot bab ni. Ini kot. Share. Participant. Share.
Only host je lah.
Sekejap. Hah? Bukan share. Oh, okey.
Okey.
Mari kita try.
Lepas tu
Hari tu
macam nak
aku
tahu
buat macam ni dulu. Yang ni connect dengan ni kan. First yang ni tekan enter. So yang ni akan dia punya.
Alright.
So yang ni kan, yang ni kau punya.
Tak ada screen lagi.
One. Yang di ni, yang zoom ni, kau kena share. Tapi kau kena share dia punya screen yang kedua.
Okey.
So bila share screen kedua, dia takkan nampak kau punya.
Aku dah letak right seorang je.
Aku dia jadi macam ni.
Okey.
Dia akan jadi macam ni, so orang tak nampak kau punya ni.
Okey. Okey, satu lagi yang pointer-pointer tu klik je lah dekat situ.
The one you right click and click laser. Right click dia punya
Sama dia ni lah.
Okey.
Laser pointer.
Okey.
Oh,
Yang ni dia direct.
Ni
Direct
memang dengar
ni.
suara
Bila
dah.
start
Actually,
dia
one thing you can make it yours full screen.
Dah start ke?
Full screen juga tau. So it's easier for you to see lah if you want.
Full screen.
Ni full screen lah.
Ni
Yang ni kita punya, ni presenter punya view.
Tak, yang
So
dekat
dia
sini
tahu
dah full
lah
screen
apa
dah.
next.
Diorang nampak muka I tak?
Nak tengok ke? Nak tengok kena buka yang
Start
video.
Oh, start video juga.
Cuba try.
Okey. Start video.
Okey, dah nampak.
Okay.
Cuma bunyi.
Test dulu lah.
Testing.
Tak ada.
Tak ada.
Okay, you click the thing, you see which is the setting for your speaker tu. Microphone.
Betul dah.
You change to
ni.
drill zero. Yes, correct.
Perfect.
Hello. Terima. Hello.
Tak ada.
Testing.
Tak sound.
Oh, bukan audio ni.
Hello.
Okey. Dia pun buka inti juga susah.
Mana video?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and good morning. Itu Prof. Dr. Sabaria and also Dr. Sonia, Dr. Emil, Dr. Ikram, and my fellow colleagues. Today I'll be presenting on Snakebite, the monitoring and the management, representing my team, Team E. Okay, so for the introduction, just so you know that majority of the snake bite cases are unidentified snake bites. All right, so we have about 400 to 650 snake bites per year. Per 100,000 populations per year, and the mortality rate of 0.2% per 100,000 populations per year. And then we need to know that there are 17 poisonous identified land snakes, and all freshwater snakes are harmless. But all the 22 species of sea snakes are venomous. So what are the classifications of snakes? Basically, there are 4 families that we need to know of. There are the Elapidae, the Viperidae, Natricidae, and also the Pythonidae. For the Elapidae, basically they have very long, thin, and large, smooth, symmetrical scales. And they have relatively short, fixed front spines, in which most of the time they cannot bite through clothes and usually deliver sublethal dose. And they do not have loreal feet. I'll show you the pictures of the loreal feet later on. And the Elapidae includes the cobra, skin cobra, kraits, coral snakes, and sea snakes. First, we go to the first species, the cobra or the naja. Basically, they are large, brown or black in color. And obviously, they have a special feature in which they have hood and hissing as well. So there are 2 major naja species in Malaysia that we need to know of. The naja kotia or the monocled cobra is marked by the monocled pattern here at the back of the head. All right. And needs to be differentiated with the naja sumatrana. Naja sumatrana is differentiated from the naja kotia based on the non-symmetrical pattern here at the chest area. Yeah. So, and then at the same time, we also need to identify the juvenile naja sumatrana, which has stripes as well, but they do not have the monocled pattern. The naja sumatrana is also known as the spitting cobra, in which it can spit venom, causes venom ophthalmia. Venom ophthalmia. Naja sumatrana. And the next one is the king cobra, also known as the Ophiophagus hana. Why is it called the king cobra? It's because it's larger than any other cobra species. It usually eats other snakes, and also it can stand very tall, in 2/3 of its length. It is marked by this symmetrical 2 large occipital scales, which distinguish this species from other cobras. Next group of the Elapidae is the krait. Usually they are triangular cross section. They have no loreal feet as well, and they are usually stripes, and the stripes are equal. Their bites are usually generally painless and go unnoticed until the envenomation takes place. So these are the major ones. They are known as the ular katam tebu as well in bahasa awam. So the Malayan krait. Katam tebu. All right. Next one is the coral snakes. They are basically small and brightly colored. While they're called coral snakes, it's not because they live under the sea, but it's because of their brightly colored. And these are the coral snakes in Malaysia. Okay. Oh. Sorry. How do I do that? Previous. Okay. All right. Sorry, Dr. Yusuf. Poison Next, we go for the sea snake. As mentioned earlier, all of the sea snakes in Malaysia are venomous. They basically have eel-like appearance, but they have flat tail. And the same as crips, their bites generally go painless and unnoticed until the envenomation takes place. The next family would be the Viperidae. We need to know that there are actually two species of Viperidae, the original vipers or the Viperidae and the Quadrilidae. But in Malaysia, we only have Quadrilidae, which are the pit vipers, not the vipers that we find in the Western countries. And they have long fangs, usually folded against the upper jaw. And the Quadrilidae is marked by their loreal pit. This is the loreal pit in between the eyes and the nostril, which is not found in any other species.
Malaysian species is not the
Yes, we only have pit vipers. And their head is triangular. So as you can see here, it's triangular, the neck is smaller, triangular. So these are some of the species in Malaysia: the Malayan pit viper, the mangrove pit viper, and if in Sabah we have the Kinabalu brown mountain pit viper as well. Yang ini tapak. Dia.
Kita yang masukkan kita kat dalam lubang dia ke panjang kan. Dia bodoh sikit lah. But the regular head is there are other species of vipers.
Okay. Then we have.
There could be in Malaysia.
Yes, we do. I mean, this is also.
Tadi kata tak ada.
Itu tak betul. The family is Viperidae, but the species of Viperidae and Crotalidae. The true vipers are the ones that we do not have. True vipers saya tak letak gambar. They're not. There's a true oval vipers, the Viperidae. They are part of the Viperidae family, but the species of Viperidae is not present in Malaysia. We have the Quadrilidae or the pit vipers. Sorry. That's weird. Viperidae family. D. Yes, it's the Viperidae family of. They are also the pit vipers. The ones present here, they are also the pit vipers. Yeah.
There is something they call it Cobra. Sometimes they call it Venoms.
Trimester. Yeah.
Hijau tu, memang highland hijau tu ya. That is the representative Camellaris. The camera highland green. Kalau kena gigit gula hijau dekat camera highland, kira
Okay, we move next.
Because there is a Sumatran viper which is also green in color. But dekat camera highland tu memang di tempat duduk dia. So it's a different species from that.
Okay. So we move next to the next family, which is the Natricidae. Basically, generally, the keelbacks are harmless to humans, but there's one identified species in Malaysia, which is the red-necked keelback, which can induce significant coagulopathy. So there's only one identified species of keelback that is actually venomous in Malaysia. Next is the Pythonidae. Basically, Pythonidae, what you need to understand is it's a giant constricting snake. So when it's a constricting snake, it doesn't produce venom. So it is non-venomous, but its bite can cause serious wound. And also usually for python's bite, we do recommend doing an X-ray of the affected limb to look for any broken fangs. So the pythons are obviously the ular sour. It's marked by its beautiful patterns. So what we need to understand as well, there are mimics, snakes mimics, mimicking the potentially dangerous snakes. So for example, the ular katam tebu just now, the banded crates, we have the gold-winged cat snake as well, but you can see that the yellow lines were thinner and it's not symmetrical as the black stripes. And here we have, if people say ular tu belang, then we need to identify whether it's a juvenile cobra or the Malayan crates. But there's also the banded wolf snake, which is also has asymmetrical stripes. And also kalau orang cakap, if people say they were bitten by red-headed snakes, usually the venomous ones have red tails as well. And if they say that they were bitten by the green snakes, the specimen is very important because we want to see the head. Sorry, this is the head. The head is basically non-triangulated as the Viperidae. So what are the composition of the snake venoms? Basically, there are many protein, including enzymes and non-enzyme proteins. In Elapidae, they have the polypeptide postsynaptic neurotoxins, and also the phospholipase A, the presynaptic neurotoxicity that causes neurotoxicity as well. In Viperidae, they have thrombin-like enzymes and hemorrhagic protease. For sea snake envenomy, it causes myotoxicity accompanied by acute kidney injury caused by the rhabdomyolysis.
So does the sea snake directly affect the kidney?
It doesn't directly affect the kidney. It's the rhabdomyolysis that causes the AKI. So what are the advices that we should give to the public regarding the first aid of any snake bites? Basically, avoid any manipulation of the wound and try to immobilize the bitten limbs and transport urgently to the hospital. Currently, they do recommend doing the pressure immobilization bandage. How do you apply it? It's basically using an elastic bandage. We wrap the affected limb from the digits to the proximal most joint. It has to be snug enough, but then you can still put in one finger underneath the bandage, in between the bandage and the skin. And after you have applied this bandage, we apply the splint to immobilize the limb further. If they were bitten at the upper limb, then the arm sling can be done.
But what I did last time is you do the bandage proximal to distal. Distal or distal to proximal. Because kalau you perah you might perah the venom. Might not, right? But why don't you do proximal to distal? This atas, right? Below the level, below the distal to the bite. So the middle of the foot is from your knee downwards. Maybe doesn't make any difference. Right? It's a matter of opinion. Right?
Okay.
Kalau I put down
Proximal to distal.
Thank you.
Next is the when patient presented to us with a snake bite, basically we do a rapid assessment and assessment using the ABCDE approach, and also we immobilize the bitten limb if it's not yet immobilized. And we always manage patient with the unidentified snake bite with the close monitoring of vital signs and cardiac monitoring. So what are the histories that needs to be taken in patients with snake bites? So basically we need to take a precise history. This is how we categorize it: when, where, how, what. So when is that precise time to monitor the symptoms? Where is basically we need to know where's the part of the body beaten and also the geolocation of the incident. As mentioned before, there are in Cameron Highland, there's a specific species. Same goes with in Sabah and things like that. And how, this is where we need to take the detailed event of the bite. What was the patient doing at that time? Was the snake has any particular behavior? The number of bites that was given to the patient, and what happened to the snake, and if possible, the description of the snake. And what is basically we discussed regarding what was done to the wound, the treatment given at primary health facilities if the patient visited somewhere else first, and what are the patient's allergic reaction. Okay. So for snake identification, this is how we try to identify the snakes, or how we consult the REX team for snake identification. We must take the picture of the dead specimen with the measurement reference, with the views of the head, 2 views of the head and 2 views of the coil specimen. So the head has to be dorsal and lateral, and also dorsal and ventral view for the body. And then we can identify using the image gallery of snakes of medical significance.
Difficult kan, trying to get the head of the snake patient. Because that's how they kill the snake if they bring it to you, right? If they bring it to a dead snake. So they have mashed up the head, and then, difficult for you, but try your best to take, maybe the Rex person can put the saw back together and try to do it. But we can have other clues to us, the shape of the body, the color of the snake will also give us a clue of to what the snake is. But one of the things that you say of what to do when the patient is bitten by the snake is that if the snake is dead, bring the snake to hospital. If the snake is not dead, please do not chase the snake. Okay, sometimes dia dah bunuh dia kat bawah. So sometimes you can ask the relatives to go, if you're not sure what the snake is, can you take back the snake and bring it here. Kalau ditanam, kalau dicampak kat longkang mana kan. So it gives us an idea. But so one of your things, your first aid part or your pre-hospital care part is bring the snake around, and please do not chase the snake. Right? Please do not try to capture the snake. Right?
Okay, then how do we examine the patients with an unidentified snake bite? We look for the fang marks over the affected limb. We must look for the local pain, inflammation, bruising, any signs of infection or necrosis. We palpate the lymph nodes of the draining lymph nodes of the limb, for tenderness and also enlargement. And then we must start our initial serial assessment using our snake bite chart as soon as possible, and if possible for consultation purposes as well, to take serial good quality pictures to monitor progress. Usually we'll take the limbs pictures in comparison with the unaffected limb. For example, this is the dermonecrosis from a Naja species bite, as seen here, 4 hours, 2 days, 5 days, and after 9 days of debridement.
Most of these snakes, especially the elephants, they're very nephrotoxic, right? And some like the pit vipers, they might not be nephrotoxic, but they're very, very painful, right? So remember, the pain management is also very important for this patient. Okay. What else in your emergent treatment can we give, before we give the anti-venom or whatever? What else can we do for this patient? What else can we give?
Pain management, and also IMATT is also recommended.
Yeah. So don't forget the ATT, right? We do get patients from San Francisco Hospital. What do they usually give?
Hydrocot and Piriton.
Yeah. Right. The hydrocot is if you develop an allergic reaction to the right. the Snakebite itself do not cause the anaphylactic reaction because of toxic reaction. Okay, so no point in your hydrocod at that point in time. Important thing is APT and pain management, and of course all the things that you say, immobilize the use and transfer. If you don't have the antivenom, transfer the patient to the next nearest hospital that has the antivenom.
And then we need to look for the neurotoxic signs as well. This is
All this information is very important for you to explain the final year for you to have this more details. Okay.
Need to remember that vomiting is an early sign of neurotoxicity, and also we need to monitor the GCS, the pupillary size. We need to look for the external ophthalmoplegia and also ptosis, trismus as well. And then we need to look for bulbar paralysis, signs of dysphagia, hoarseness of voice, any slurring of speech, and examine the neck muscle. Some patients with neurotoxicity may present with the flexor of the neck muscles paralyzed, so they have the broken neck sign as shown here. This one, most of the documentation is that the Naja species in India.
The ptosis is very good. If one of the earliest you can see is ptosis. Right. So ptosis represents already a systemic inflammation.
And then also when their breathing is already affected, then we can see the paradoxical respiration on this patient. Next, we also have to look for the hematotoxin signs, basically any bleeding tendencies, any traumatic bleeding from recent wounds or partly healed wounds, and any spontaneous bleeding from any mucosa or any orifices. In pregnant lady, we might look close for antepartum hemorrhage.
So the bleeding from the flank sides, right? Usually, kalau you tengok Cobra flank side, you just see just two spots, right? And lepas tu dah cover with a clot or a scab, right? So if you see the flank mark, which is continuously oozing, slowly oozing, right? So include that because there might not be other wounds. Most of the time they're not other wounds. So that will be a first indicator for you to look at the flank mark whether it's bleeding or not. What kind of inflammation is this? Ini semua dah lambat-lambat dah factor bleeding semua kan.
So basically this is the summary of all the signs. Basically the bite from cobra and pit vipers will cause pain and also swelling. You can have tissue necrosis in vipers bite, but it's rare. Blisters are mostly present in pit vipers bites. Can also be present in cobra. The neurotoxic effect, of course, in the LRPD group. And then the hematotoxic effect in Viperidae, the rhabdomyolysis in sea snakes, and as mentioned before, that patient with crates and also sea snake bite may go unnoticed, but the sea snakes usually can come with presentation of generalized muscle pain and tenderness due of the rhabdomyolysis, basically. So sea snakes can present with trismus, myoglobinuria, and also AKI. What are the investigations that we need to take? Basically, in a hospital that's fully equipped, these are the things that we take. FBC, RP, coagulation profile, CK, urinalysis.
What is your coagulation profile?
The INR, PT, and APDT, but mostly PT, APDT.
But this hospital is INR and PT.
INR coagulation profile, so PT, APDT, and INR. We always hear about the 20 minutes whole blood clotting time test. This is only done when coagulation profile is not available. Okay, because the positive test is not an indication to start an anti-venom. Right, but we do need to know how to perform it. Basically, we take 2 ml of patient's blood into a clear, clean glass bottle, usually the Bijou gel. And
glass bottle.
That's a Bijou bottle that we take for LP usually.
Dari simpan kita ini. Kalau tak ada kan, kita lagi kita next week kita glass bottle for the LP kan. Right.
And then we leave it undisturbed for 20 minutes and we turn it once after 20 minutes to see whether there's any clots or not. As mentioned.
Yeah, it's still useful. if you say your coagulation profile, it takes 2-3 hours for it to clot, right? Of course, like your decision is always clinical, whether you want to start your anti-venom or not. But if you need to do something just to serve yourself, like, you want to treat yourself, right? Then you can do this. Because sometimes in the very busy hospital, tell me that PT can take 1 hour. It take 20 minutes to do it. You get 20 minutes to get the bottle somewhere. Right? But it still has its uses. Some of you might later work in a district hospital, lagi lambat datang malam, lab are not active at night, only come in for you to do some urgent tests. Right, so there's still a role, so you need to know how to do. Who knows, we will send you to India ke Cameron Highland ke masuk hutan ke kerja dekat one di kesihatan ke mana ke. Some of you especially interested in wilderness medicine, yeah? Right, some of the simple tests are it's quite useful. So how many cc's you take?
2 cc. So how do we document the diagnosis of
What are the tests what are serial tests that you do?
serial tests?
Serial tests.
The
Is it coming?
serial, yes, it's coming.
Okay, it's coming.
So how do we document the diagnosis of a snake bite? Basically, we do not document as alleged snake bite anymore. We don't put the word alleged. We either put unidentified injury, unidentified animal bite, or unidentified snake bite. Identified snake bite only when it is confirmed by visual confirmation and also venom ophthalmia. So these are the examples of how we write it. When the species is confirmed, then Naja sumatrana snake bite. If it's not confirmed, unidentified snake bite with or without envenomation.
Now, not a venomous snake, how you put the diagnosis?
I will go ahead Python snake bite.
Grass snake or whatever, kacau something, give you a bite, maybe kacau snake or whatever, right? But it's not venomous.
We can write as a unidentified snake bite with no envenomation. So the monitoring, this is the serial clinical assessment that needs to be done, in which we monitor the vital signs pain score. The RPP is very important, rate of proximal progression, and also the lymph nodes. Hold on, I'll show you. This is the chart. This is the snake bite chart that we need to fill up. Basically, this chart is filled up preferably every 2 hourly, because that's the monitoring. But the RPP, you need to remember, even though we document this chart 2 hourly, the RPP has to be documented every centimeter per hour. So whatever rate that we get, divided by 2, and then we get the centimeter per hour. So how do we measure the RPP? Okay, so basically we find the proximal most area of the swelling, and we mark it with the micropore, and we write a clear date and time on the micropore. Okay.
Lama dah saya tak nampak yang dia ambil marker pen dan dia di situ ni. Semua dah pandai sikit lah sekarang.
So do not use a permanent marker to mark the area.
Pandai fikir permanent marker tadi. So after a couple of years, the message got through, right? Semua buat ke ini, tahulah. Tapi kalau semua tak pakai ini, mana dia tahu? Tahu tak? Mesti ambil marker pen. Dia tak kot. That's all kita nak suruh orang harus membuat. Ini you send to the district, you see a mark, and then you ambil marker pen, and then you right.
Okay, so as mentioned, we measure it every 2 hours or 3 hours, and then we divide the documented to be the measuring, the unit to be centimeter per hour lah. How do we measure it? Basically, it can be either from the upper border to the upper border or the lower border to the lower border. So usually we take from the upper border to the upper border lah, to make it synchronized. Okay, so this
is the, yeah, into RPP. What is the significance of it? What is the rate that is significant? It's important. Yes, you can agree. I check the technology. I check. But when is it significant?
From the guideline, it is not mentioned specifically the rate, but then it is said that within 48 hours, if the swelling is progressively increasing in size, involving half of the bitten limb, then it is indicated for an anti-venom.
48 hours.
48 hours.
So you still can give venom after 48 hours.
Anti-venom. Yeah, anti-venom. So how do we monitor the blood investigations? These are how we do it. For any unidentified snake bites, we basically monitor every 6 hours of LBC, coagulation profile, and CK. RP, LFP is only done as baseline. For sea snakes, identified sea snakes, then we need to do an RP 6 hourly. For pit vipers, same 6 hourly of the LBC, coagulation profile, and CK.
Why for pig we do cracking kinase?
This is
Species. Yeah, that makes sense. I'm talking about pig vipers. Why we do cracking kinase? Yes, I understand that. Elipid also why I'm doing cracking kinase at 6 hours.
LFP can cause myotoxicity.
Huh?
LFP can cause myotoxicity.
Minus is cardiac toxicity, plus myotoxicity. The peak, I'm not quite sure why. Right? Tapi, since the pakar tulis itu, ikut je, saya pun tak tahu pasal itu.
Misalnya ambil dekat guideline.
Yeah, that's why I meant. Yeah, this is the Malaysian CPG.
Yes.
Bukan yang bukan the toxinology. Because we gathered the specialists. DPPs from PKM, from industry, of course, we have our pakar ular, our reps, and we also got the medical, and we also got orthopedic people in. Okay, then later I'll explain why we did orthopedic people in. Okay, so they come back quite a bit like okay.
And this is how we document the serial bloods. We have a chart as well included in the snakebite chart. Okay. So general measures, as mentioned before, pain management, analgesia, we must, it is to be given as per the pain ladder, but we must avoid IM injections and NSAIDs. This is taking into consideration that it might be a hematotoxic snakes. And we treat the complications and then the anti-venom therapy. So the anti-venom, when to give, basically when there's any one of these signs present. For systemic, there's two criteria, systemic envenomation or the local envenomation. For systemic envenomation, there's the hemostatic abnormality, neurotoxic signs, cardiovascular abnormalities, any AKIs, myoglobinuria, or any signs of intravascular hemolysis or general rhabdomyolysis. And presence of any one of these signs is warranted for an anti-venom treatment. Same goes with local envenomation. As mentioned before, local painful swelling involving more than half of the bitten limb within 48 hours of the bite. Rapid extension of swelling or significant swelling after the bites on the digits. Right, and also development of enlarged lymph nodes, either tender or non-tender. So any of these, one of these warrants for an anti-venom as well. So how do we administer an anti-venom? There are two types of anti-venom, monovalent and also polyvalent. It is given, all anti-venoms are given through IV infusion, and the dose is the same regardless of the age or comorbids. There's no like linear adjusted dose, something like that. So how do we do it? Is we reconstitute first the vials using 10 ml of syringe water and subsequently dilute it further for adult in 250 or 500 cc and in kids in 5 to 10 ml per kg of body weights. But we can also use this for adults with strict fluid restriction in which we want to reduce the dilution further. It is also stated in the guideline that we can actually give the anti-venom without further diluting it for for those yang memang betul-betul we need to restrict the fluid. So how do we give it? Is we give an infusion rate of 1 to 2 ml per minute over 10 to 15 minutes first, and then to increase it to be completed within an hour. So because we need to look out for signs of anaphylaxis.
Yeah. Kalau dulu di anti-venom, they ask you to do test dose. Like what we used to do test dose when we give penicillin, we don't do anymore, right? So that's why they say in the first few minutes you run this slow, then you can complete the dose, right? So no need test dose.
Okay, so these are the anti-venom that are available in Malaysia. Please take note that it's all Thai anti-venom. We no longer use the India anti-venom. And then for the monovalent for identified snake bites, we basically give 10 vials for the cobras, and also for the crates we give 5 vials. Only for the Malayan pit viper to be given 4 vials of 40 mils. If we are using the polyvalent, for the neuropolyvalent, it is to be given 5 to 10 vials. This is depending on if it's a local envenomation, we give 5 vials. If it's systemic envenomation, we give 10 vials. Okay. For sea snakes, we get it from Australia.
You know how much a vial costs?
For sea snake,
Any generally on average per vial 5,000. Besides fish everything. And then you prepare the thing every day. So we don't have mono. Tak banyak. Tak banyak lah. But 3,000 plus. Dia tadi buat provide kan? Kita provide. Sekali ini 10 vial. First dose. Dan kita tak kata bila kita top up.
ada.
Kita bila top up ke mana? Dah tadi berapa ribu? 25,000 5,000.
Actually, to be top up for the neurotoxicity every 1 to 2 hours, and for the hematotoxicity 6 hours.
50,000 to maybe sometimes about 100,000 per patient.
All right. This is the ones that I take from our CPG as well. For coral snakes, there's no anti-venom available, so they do recommend considering anti-cholinesterase drugs, atropine and neostigmine to be given for patient and to be observed for the next 30 to 60 minutes. And if there's improvement, patient can be started on maintenance dose. So, what are the side effects of anti-venom?
For the neurotoxic, for the neurotoxic, let's say a Cobra bite, a Cobra bite, not so much on the neurotoxic effect, mainly on the neurotoxic effect. Somehow either you on an island, you're on an island. Somehow other, because you crash landed there, you have your incubation cell. Right? Okay. Then you have this portable ventilator, you know what nowadays after the COVID, all sorts of nice, cheap portable ventilator. And then somebody was talking about what we right? Then patient went into respiratory work, integrated disposition and ventilated disposition. Right. Is that management enough?
Yeah.
If you don't have the neurotoxin, because one there's a patient on neurotoxicity die. Where did they die? Yeah. Data toxicity. It's not the toxin is toxic to your brain and then toxic to your heart. Yes, it might have the myotoxic effect. Yeah. Yes, it doesn't have the myotoxic effect. It is the neurotoxic effect. Right? And then, so they die from respiratory compromise. So you ventilate this patient whatever how long you need to ventilate until the body gets rid of the toxic itself. Okay, tak?
Not sure.
I think it can be done. Right? Because those were the days we used the useless Indian. That's what we do, like we ventilate patient. Yeah, that's I like that. I that's like we used to use the Taiwan. Right? But we need to get them. Then they got well, we don't know from the Anti-Venom or from the, you know, they got, yeah, they got well after the period of that. Because we don't know, not quite sure whether the effect of the venom sticks to your nerves, to your neural tissues permanently unless you give anti-venom. I don't think so. I think the body is quite good in getting rid of things like right? There's something for you all to check. Siapa yang final year ke, second year ni, okay? Please check this one. Even anti-venom for a neurotoxic effect, right? Can I just ventilate this patient until the patient recovers his full ventilation blank? Okay.
As mentioned earlier, regarding the side effects and reaction that we need to look for in a patient who receives an anti-venom therapy, we need to monitor during and at least 1 hour after administration, because the early signs, of course, patient will develop anaphylaxis within 2 to 180 minutes of given the anti-venom, and also they can have pyrogenic symptoms within, effects within 1 to 2 hours. Hyperthermia and also vasodilatation causing PP crash, and also they can present with a late presentation 1 to 12 days after of an allergic or sodium sickness type reaction, nausea, vomiting, very unwell, myalgia, arthralgia. Okay, so response to anti-venom. How do we monitor the patients whether they are responding to the anti-venom or not? Generally, they feel better. Their symptoms improves. There's no spontaneous breathing. It stops within 15 to 30 minutes. Blood coagulability will be restored within 3 to 9 hours. If patient is in shock, the BP will improve within 30 to 60 minutes. The arrhythmias will be resolved. Neurotoxic. Because of the hypovolemia.
So if you're bleeding so much, I don't think you're going to improve within 30 to 60 minutes by the anti-venom, right? So, you think that this BP, you said BP and hypertension, what is it due to?
Probably for those with arrhythmias, cardiotoxicity,
Right?
cardiogenic shock.
Yeah.
And then,
So it's neurotoxic. Is it neurotoxic only to the post-ganglionic fibers or the muscle fibers? Or is it neurotoxic to all the fibers, all the nerves? So we are talking about your sympathetic nerves, your parasympathetic nerves, right? And the nerves. So iron neurotoxic. So if you have neurotoxicity to your autonomic nervous system, that can drive to the BP and of course the cytotoxic effect. So if you give the anti-venom, that's what it works. I doubt it if they're bleeding to death. If you're hypotensive from Vaporidae, then you know you're big trouble. I don't think by giving the anti-venom you're going to get the blood pressure up at that point in time. It's more than that. So when you all this very significantly improve, right? Tadi pun tak nampak hypotension as a cause of your sign and symptoms of the. They suddenly got BP improve. Then kita ada connection lah.
Okay. Next is the neurotoxic effect will improve as early as 30 minutes, but sometimes it can take hours, and also for the hemolysis and rhabdomyolysis may take hours as well. So how do we know when to repeat the anti-venom again? Is if the blood remains incoagulable in 6 hours after the initial dose, there's a patient who continues to bleed briefly within 1 to 2 hours after the initial dose, or persistently deteriorating neurotoxicity or cardiovascular signs. Then we repeat again after 1 to 2 hours. Regarding the treatment of the beaten part, there are 2 treatments that are mainly to be given to the patient. There's a debate regarding fasciotomy, the indication of fasciotomy for patients. From our CPG guideline, they do not recommend fasciotomy at all until the anti-venom therapy has been fully optimized and hemostatic abnormalities have been corrected. This is because snake envenomation causes superficial edema and rarely increase the intracompartmental pressure. And the studies also show that anti-venom will reduce the intracompartmental pressure to prevent further myonecrosis. That's the reason why the treatment for a patient with a progressively swollen limb is the anti-venom, but not the fasciotomy.
That's why we got the orthopedic people in the group. But the ortho will do fasciotomies before. Right, so to make them understand what they should, what the orthopedic in the group. So which means that their guidelines also now they understand it. So ortho don't do fasciotomy because sometimes you might know when they go to ICU, when the patient end up in ICU, those people up there they might not understand. Then they refer to ortho, also say big name, then they do a fasciotomy. So we need to educate all the chain yang treat this patient.
And same goes as debridement for the dermonecrosis. It is usually done, it can be done and usually done when there's a clear demarcation to reduce the extent of the debridement. Regarding the venom ophthalmia, this is of course caused by, just now mentioned, Naja sumatrana, the sleeping cobra. So it needs decontamination by copious irrigation. For analgesia, patient will complain of pain, so we can use letrakian drops or LD 0.5% ophthalmic solution to provide pain relief, and then we apply as an early referral to the ophthalm team. So the disposition, basically patients that is indicated for observation and admissions are those with snakebite with local and or systemic envenomation, any venomous snake bites, any unidentified snake bite or unidentified animal bite, they need observation. So as mentioned earlier, there's the REX team, or known as the Remote Envenomation Consultation Services. They are there 24/7. It's a teleconsultation. So we can send our referrals with the pictures and the progression of the patients, and we will be given a directive treatment for the patient.
Ular dia sembunyi. Covid tadi tu ular pun sembunyi keluar.
Orang tak keluar jadi ular tak
Orang tak keluar.
Orang tak keluar.
Betul. Ular tak keluar tak kacau ular. So bottom line is we are the one that disturbing the snakes rather than the snakes that attacking us.
Okay, so that's all sama the management and snakebite guideline lah. Thank you.
Something to add regarding the venom ophthalmia. Okay, is it indicated to give anti-venom if you have venom ophthalmia? No, it's not. Yes, it's not part of it. And then one more thing that they miss is doing a fluorescent stain. Yeah, because you must treat it like a chemical splash, the same mechanism. Okay.
Okay. There's also an additional probably guideline. It stated that tranexamic acid and vitamin K is also not it's not shown to be effective in patient with hematotoxicity. And also antibiotics can be given for patients with clear signs of infection over the affected limb. Thank you. Questions? Macam nak tengok question kat sini.
Yang ada usaha tu nak istat. Yang ada usaha. Yang ambil anti-venom daripada Singapura. Oh, ya.
Share some experience. Just to tell you that we have a networking of anti-venom procurement in case you have some exotic snakes by your patient. We have a patient dia kerja dekat ICT. So dekat ICT ni dia simpan exotic snake untuk penilai. So what happened was in the middle of the night, he was playing with the snake. Katanya dia nak bagi snake makan, tapi sebenarnya I think dia main snake juga. So he got bitten. So when he came to us, his PCS was poor, was going to be didn't get any sleep. Then until they kulit datang lebih dahulu. So when they came and told us that he was bitten by a snake, the snake they described as a rattlesnake. So dekat negara kita tak ada rattlesnake, kan? So masa tu we had problems in
Michael ya.
Rattlesnake dia
Yang kata orang tahu Michael tu dah.
So masa tu because he has indication untuk anti-venom because he was neurotoxic, he showed signs of system envenenation, neurotoxic, and also dia macam ada hematotoxin juga. So dua-dua lah. So we don't have that specific anti-venom, and so we gave him a poly. So it didn't work. So in the morning dia dah dekat ICU dah. Then they saw that he deteriorated. So what we did was we contacted kita punya pharmacy, and our pharmacy try to look for the anti-venom in the other countries. So kita orang call Thailand, Singapore, and then ada mana lagi tak? And it so happened that Singapore punya zoo ada rattlesnake. So dia sebenarnya dia punya instruction is if you keep that snake yang exotic tu, you should have the anti-venom there because in case you punya staff kena lah. Tapi dalam ICT tu they didn't have that lah, so they got in trouble. Okay, then what we did was bila kita tahu kata zoo dekat Singapore ada this anti-venom, we use kita punya pharmacy connection between Malaysia dengan Singapore to get the anti-venom into Malaysia guna yang this emergency punya pathway. Sebab kalau ikutkan, you kena ada some specific pathways yang it's going to take a long time just to get the anti-venom imported into Malaysia.
Now lah, you got the emergency.
So dekat sana, pharmacy sana okay, we'll get it into your country. So dia zoo Singapore tu bagi dekat pharmacy tu, and then naik Air Asia sampai dekat KLIA. So we took from KLIA pergi ke ICU and then give it to the patient and give it.
How much is the patient pay? So how much is on the government Asia? This Singapore give it for free.
The government pays us.
More than 300,000 sampai.
Anyway, the moral of the story is bila you dapat patient yang ada exotic punya snakebite, get the pharmacy punya networking active early. Because you might get the anti-venom from the other countries ataupun the other areas.
Okay, just let me see that. Just to let you guys know for the C-state anti-venom memang kita tak ada. Recently, we renovate the place and the price is a bit higher. So in H1 they keep it and also in one hospital. So kalau ada cases, dekat tu tak? Dekat Tanjung Karang saya rasa macam tak ada. Tak ada. Dia ada neuro dengan hemato. So dua hospital simpan, but it's very easy to get lah. So dia pakai connection as what Dr. Hizan kata lah. Yeah. Network is very, very strong. So if there is any case, then you should actually escalate it to the special level. So reason being sebab kita jarang dapat, so it tend to expire and not worth it lah. It's very expensive. Ya, yang untuk neuro tu kita ada, neuro memang ada neuro polyvalent, but mono tu kita ada satu saja pun, which is Wanajang Mafia. So the commonest thing lah kan. Viper kita ada juga mono, tapi Viper jarang lah, we mainly get the neuro. I think majority of the cases are from Tanjung Karang. Masa 2020 memang kita tak dapat Snakebite sebab semua I think goes to Sedayang, Sandra. But in 2021 kita dah start notice sikit, walaupun kita full hybrid, I think we control our staff kan. Kalau kita nak terima Tanjung Karang, kita ambil je. We do it quietly and then we refer out lah kan masa tu. So as you understand that now, even though we give another 4 weeks of class, just to let you guys know lah, pre-hospital care we have actually not say reduced, we have stopped targeting for the red zone cases and yellow zone cases. That's why we nampak the numbers a bit higher on the non-COVID side, right? But we have to do that, otherwise we'll be full COVID forever, right? Then so just be prepared. Just treat all the patient as COVID so that you are wearing your full PPE. Most important dekat klinik ini just pakai face shield lah. Majority total number of staff yang dah COVID positive during this Omicron is almost 80 patients. 80 staff. Tapi semua dah RO dah, especially now lagi cepat RO. Yeah. So yang tinggal I think about 20 sahaja. Itu pun dah nak RO dalam 2-3 hari lagi lah. But all kategori paling highest pun kategori tu A lah kot. Ada lah tu B pun tak ada kot. To A, kebanyakan ni to A lah. Yeah. So please take care of yourself. The other degree, I know that is a bit milder, but kalau you notice, because the number of cases are very, very high, the percentage of VID pun akan increase sebenarnya, not because of the virulence of the virus, but because the numbers, the denominator is increased, so atas will increase. And if you hear that people are saying that orang sekarang lagi ramai orang completed booster yang BID or sorts of things, it's just because the denominator is higher. Sekarang tak ramai yang non-vaccinated or non-boosted, so memang akan tinggi lah. But majority of the cases yang dekat national mortality, majority are above 68 years old with comorbids. Right, so just be careful. Status of vaccine has to be ascertained upon arrival, and then I've already asked Dr. Ben, the vaccine status is not indication, is not a criteria to go to PTKM. So kalau dia tak vaksin pun, tapi dia stable, boleh jangan pergi to PTKM. If they deteriorated very fast, they should know how to do it lah. Because medical MO dah ada test tu, specialist MO dah ada test tu. So ideally, sepatutnya tak adalah activated code blue untuk ED to respond, tapi ED provide the transport lah once they are stabilized to be transferred to the ward directly. Because remember dekat PTKM dia dah ada line A which means that the 80 beds oxygenated ready. Ideally, high flow mask pun dah boleh letak dekat situ. It's just that the training of the MOs and the nurses is still the limitation. Sebenarnya we are pushing that even face mask 5 liters pun boleh pergi sana directly. What they are saying dekat sana only for step down, but I think we should start to take this case now. Yeah, yes, semua masih tak. So kalau you notice that Fakta is being pushing to go to more PTKM. Kalau dia bukanlah nak istilah lah, kalau dia collect kat sana pun there's always MO medical specialist medical kat situ. Kalau tak boleh juga resuscitate, okay lah, we'll give advice before we arrive there. So jangan takut hantar pasien kat sana. Selagi kita tak atas lagi tu dia like mentally PTKM yang zaman dulu lah. Masters and NP, family registrar sebenarnya yang
Dr. Hafizan bercerita pasal this snake charmers ni kan, ini think about this, they repeatedly get anti-venoms. Right. So what will happen to the patient? Remember, if you give streptokinase, you're not supposed to give it until how long? Every 6 months, ada kata 6 months, ada kata 1 year, ada kata 2 years. Why? So you develop antibodies against it. Right. So those that have frequent antivenoms might not work anymore and might cause directly the antibody reaction to them. So again, a problem for these charmers if they get themselves bitten many times and they have systemic elimination many times. You can't give them anymore. Right? It doesn't work anymore. Right? Because they have a reaction, because they develop antibodies should be given antibody, because they give the antibodies again, antibodies again. Okay, so these snake charmers, difficult patients, difficult people, so just take note. Okay. Because your later on for the masters, especially your administrative colleagues, and you give the antivenom, but it doesn't work. Farah is a snake charmer. Berapa kali sudah dapat antivenom? 10 kali.
Ada makan ke?
Ada. Ya, jemput semua untuk makan. Terima kasih. Thank you.